Hello, folks. It's Beth Wright, and I am podcasting your last unit. This is Chapter 37 for NUR 136, Unit 5. And in this unit, we're going to be talking about constipation and elimination problems. And so this is going to be talking about basically laxatives and stool softeners. And when we're talking with our clients about this end of the body issues, we got to always keep in mind about being sensitive to this because, it's a private conversation. And we also need to remember to be providing privacy. We don't want to, go in there and start talking to them about all this. If they've got a room full of company, visitors, if they're in a hospital setting or wherever, because it is a sensitive issue, it's a private issue, and a lot of times it's can be an embarrassing issue for clients. So we got to always remember that. Now you're going to find there's patients, especially our elderly patients, that are kind of fixated on the bowels. Okay, you're gonna hear that. I know my mom used to say, it seems like that's all I talk about is my bowel movements. And she had a lot of bowel issues, and a lot of elderly patients do have a lot of issues with their bowels. So, expect that, expect to be seeing that kind of thing. You may find some clients that are literally dependent on laxatives, and, it could be a psychological thing, or it could be, misuse of the agents or things like that. It could be a physiological thing as well. But we need to investigate it. We need to assess it and see, is there in fact issues that, the patient doesn't know about, or, the diet, for instance, are they having enough fiber in their diet? Do they, drink enough liquids in their diet? Do they have activity to help that peristalsis to occur? So we need to assess it, the situation, and we always want to do things the natural way if we can and avoid taking any kind of medications if possible. So that's going to require some assessment on your part. And if in fact we find, yes, they're indeed going to need something, then, a lot of these products are over the counter, and, they can, we as nurses can help guide, what is it that they need? Do they need a stool softener? Do they need a laxative? So we can help them with that and guide them with it. So the one thing, be sure, is that is very, very important with this, is that we never want to give a person with an acute abdomen. And when I say that, I mean someone that is just all of a sudden having severe abdominal pain. We never want to give them a laxative. If somebody's having nausea and vomiting, we never want to give them a laxative until we rule out that they don't have some kind of an acute situation, such as an appendicitis or an obstruction in the bowel, because it can cause the bowel to perforate, to rupture. And so we never want to give anyone like that a laxative, for sure. Okay, so let's talk about laxatives. They cause a mild effect. Uh, and, I don't really like the word mild here because it can have a mild, moderate, or strong effect on a person. But anyway, and it supposed to cause the elimination of soft form stool. Okay. Now the word cathartics is a strong effect and elimination of liquids and or semi-liquid stools. And when we think about the word cathartics, just that means purging or cleansing. Okay. Been around, that word's been around a long time. And, it's a good word to use for laxatives for sure. Now, of course, the effect depends on, what they take and the dose that they take and what, uh, how severe it is. So oftentimes all of these terms are interchangeably. So when we think about the action of defecation, let's think first about the word peristalsis, okay? Peristalsis is what happens, how your bowels move, that involuntary movement that goes on that we don't really feel. We don't really see it. We shouldn't see it. There may be times when you do see it, and that's certainly not normal for us to see that. But anyway, peristalsis is that movement where it gets the food and the nutrients and all that going down through the GI tract through the intestines, and the absorption and of nutrients and all that is occurring as that peristalsis is happening, and then eventually the all of that nutrient stuff starts forming stool. And so when it gets to the anal end, that's where your cerebral cortex controls the reflexes there that's needed. And we hope that that can occur at an acceptable time and place for sure. And normally stimulated by movement and reflexes in that GI tract. And a normal bowel elimination should produce a soft formed stool without pain. And we always need to address any kind of any time a patient is not doing a bowel movement for 3 days. And it's not normal if you're not going to the bathroom at least every 3 days. And everybody has their own pattern, and that's what you'll find when you start assessing your patients. And that's one question we'll ask them. When was your last bowel movement? That's part of your GI assessment. And they may say, well, I haven't had one in 2 days. And you may think because you are an everyday person that that's not normal. But we got to then ask them, well, how often do you normally go? Is that your normal thing? And if they say, well, I normally go every day, then you might need to be concerned. But if they say, well, I don't go, and I usually go about every 3 days, then we understand that that's going to be their normal. So we got to ask those questions to understand what is their normal. And if if it's not every at least every 3 days, then we need to address that, because that stool that's staying in this body like that. And of course there's bacteria in stool, and we don't need to keep it in there any longer than 3 days. When I worked hospice, it was an automatic thing that when we put patients on medicines, and I was going to talk about this later, but I'll talk about it now. For pain medications, one of the side effects of your opioids and most pain medicines is that it causes constipation. And so it was an automatic. If a patient was on an opioid, they were on a stool, softener at a minimum, if not some kind of a laxative. So we gotta keep that in working too, because it's important. When that gets messed up down there, then people are miserable. Okay, constipation is in people who often inhibit the defecation reflex. And I'll give you an example there. My kids used to say, I'm not using the bathroom at school. And so when they got home, a lot of times they were in the bathroom for a little bit because they would not use the bathroom at home. Um, or failure to respond to the urge to defecate, constipation develops, and those reflexes can weaken. Um, Constipation involves infrequent defecation, of course, and due to various variations in the diet or other factors, there is no normal number of stools, but the traditional definition includes 3 or few bowel movements per week. And the Rome 3 criteria that's listed is an organization, non-for-profit organization that studies functional gastrointestinal disorders, and one being constipation. And they have criteria that, specifically addresses constipation. And, for irritable bowel syndrome, constipation can be a part of that symptom for that. And so the clients would follow under that Rome 3 criteria. So our symptoms of constipation is, of course, straining. And, anytime you strain, you're putting pressure on vessels and everything else down there. So there may be an issue with hemorrhoids as well. The sensation of incomplete evacuation, and then a sensation of anal rectal blockage. Hard stool, meaning that the consistency of the stool is hard. And manual evacuation. So this is where literally you put on a glove and you have to manually dig out the stool from the rectum. And that sometimes is required of patients. Not a fun thing to do. So we're going to talk about ways of how we can get that done or avoid getting that done. So, the true and false question, traditional medical definition of constipation includes 3 or few bowel movements per day. So, did you read the question? Okay, is it per day? No. So, that's a false. It is per week. So, you got to really read your words when you're looking at these questions. Okay, so risk factors, of course, is going to be diet. If they don't have a lot of fruits and vegetables, that have the fiber, in the diet, then we're going to have an issue there. The lifestyle, are they active or are they mainly sedentary? And some of our elderly can't help but be sedentary, so we got to think about that with respect to our physical activity there. The female sex is, more prone to have constipation. Non-white status also is advanced stage, and then, lower levels of education and income has been found to have more issues with constipation as well. So that's why it's important for us to do that education. So measures that we know we need to teach the patient about to prevent and treat is the importance of that diet, exercise, and fluid intake. Fluid intake is huge in this to help promote the normal bowel function and prevent constipation. Of course, increasing that activity and exercise if possible. And the dietary fiber, we always want to include that, and at least 2,000 milliliters of fluid a day if it's not contraindicated. You'll see that will be contraindicated in folks with renal issues, renal failure, or renal insufficiency, and heart failure patients as well. They're usually on a restricted diet or fluid intake. And then also, trying to establish and maintain a routine for bowel elimination can be something that we can teach the patient about as well. So indications for the use of laxatives is to relieve constipation in special populations such as pregnant women, elderly patients whose abdominal and perineal muscles have become weak and atrophied, children with megacolon, which is when the colon is enlarged because there's so much stool in there, patients receiving drugs that decrease the intestinal motility, such as the one I was mentioning, air opioids medications. Also remember about anticholinergic drugs, or drugs that have anticholinergic actions. Can't pee, can't see, can't spit, can't pee, can't, poo. We'll say poo. So those can cause issues there. to prevent straining at defecation by specific populations. So when we're talking here, we want to be especially careful on the straining thing with folks who have coronary artery disease, like someone who's had a heart attack, folks who have hypertension, folks who have cerebral vascular disease, such as a stroke or things like that, hemorrhoids and other conditions, because that straining causes, again, pressure on those vessels, and they can kill over when they strain on those vessels. So we want to be real careful about that. We want indications are also as a bowel prep, so for surgery, so to empty, or let me just mention, not just for surgery, but also for radiology procedures. Sometimes we'll see this as well. So it could be diagnostic procedures such as a colonoscopy or barium enema in the radiology department, or any surgical procedure where it might be of the bowel, or the abdomen area. So we want the patient to be cleaned out. So, a colonoscopy is this endoscopy procedure where they take the scope that has the camera at the end of it, and they go up in the rectum and go into the colon to look around to see if there's anything wrong. And, obviously the surgeon who is doing this cannot see what's going on if there is a bunch of stool in there. And so you've got to get the patient cleaned out. Cleaned out as in cleaned out very well. Like cleaned out as in nothing there. And, most of the time when we're seeing this done now is the patient's doing it at home before they come in. There's times when you're going to have to do it for patients who are already admitted to the floor, and we'll talk about that when we come up to that medicine, the medicines that they use for that. But you want to have the bowel cleaned out so that the surgeon can see, because if he gets down there and there is stool in there and they can't see, you're going to have the patient go through an unnecessary procedure and get medicines that are heavy duty risky, that's put them in a sedated state for no reason. And so we got to make sure that bowel is cleaned. And last and least of important, but it is important, is you're going to have a mad surgeon for sending a patient down that is not prepped. So anyway, been there and done that, and that is not good. All right. We use it for accelerating bodily elimination of toxins. Sometimes you may see that if somebody's ingested a drug or a toxic compound and they are using that to get it out. They'll use a strong laxative to get that out. Preventing absorption of ammonia for impaired hepatic function. So there's times when our patients with liver failure, and it could be alcoholism or it could be drugs that's caused that, but whatever the reason, they can become or get a condition we call hepatic encephalopathy due to too much ammonia, and I'll talk a little bit more about that here in a minute. And so we'll use a specific type of laxative to help get that ammonia level down. We also can use it to help us get stool specimens, and especially when looking at parasites and things like that, like worms. It can help to excrete parasites such as worms. And it can also be used to help reduce serum cholesterol levels as well. So drink at least 2,000 milliliters a day to assist in the prevention of constipation. And hopefully you answered true on that. Okay, contraindication. undiagnosed abdominal pain. Why? Why do we want to do that? Because if there is a blockage in there or some kind of, irritation going on, inflammation going on, such as appendicitis, if we cause that bowel to have intense peristalsis, because that's what we're talking about here, if we give them a laxative, that's going to cause intense increased peristalsis, we could potentially rupture that issue. Okay, we could that part of the bowel, and so we don't want that to do, because if that ruptures, if you get a hole in that, think about where that stool is going to go. It's going to go into the peritoneum. It can set up a condition called peritonitis, which is not good. And just think about having stool in your abdomen, in your peritoneum, in your peritoneal area. Not good. Not good at all. That is an emergency type situation. So we don't want to cause peritonitis, and that's why we don't give it to anybody that's got undiagnosed abdominal pain. Oral drugs are contraindicated for intestinal obstruction, just because of the reason we talked about there, and fecal impaction. So what that means is the patient is impacted, meaning that stool is in there and it's not coming out. It doesn't matter how much, laxatives you give them. It's not coming out. And this is where we have to manually remove the fecal impaction. Again, with a glove, and you just go digging. That's exactly what you do. And you also use a lubricant at the end of your glove to help do that, and other things to help soften up that stool. But I have had to do that many times, and you will too. It's not a fun thing to do, but I tell you, once that is relieved on a patient, they will love you forever. Because when that happens to individuals, they're absolutely miserable. Okay, so let's talk about the types of laxatives. We have bulk-forming laxatives, and what those do, they add mass to the feces, and that stimulates peristalsis and defecation. They must be taken with water to avoid obstruction. So it's like a powder thing, and you gotta mix it with water, because if the patient does not mix it with water, or we don't mix it for them with water, then it can cause major issues with the patient. So we got to definitely teach about that. One nurse was telling me a story about she had a nurse to come ask her to check a patient because she thought the patient maybe had rabies. And when she went into the patient's room, the patient was foaming at the mouth, and she noticed a plastic medicine cup on the overbed table, and she asked the patient what had been in that, and he had said that was a Metamucil, and the med nurse had left the dry powder in the room and to go fill the patient's water pitcher, and the patient just went in there and just went ahead and took that medication. And sorry about that, I had an interruption from the grandson, but I want to finish the story for you. So anyway, what had happened with this gentleman was that he had just put the powder in his mouth and tried to, he thought that's what he was supposed to do. And it just started foaming up in there, and what can happen is that can cause an obstruction. So we definitely need to go in prepared, or at least take the medicine back with you if that happens to you, because that can definitely cause a rupture of the esophagus, and that kind of thing. So it needs the mixing of the water needs to take place at the bedside. Uh, just going prepared is important. And if you didn't go get in there and get prepared, then we certainly want to take the medication back with us, okay? That's very important there. Psyllium products are your main bulk forming laxatives there. And, you know, they do have a high amount of sodium and or dextrose in them. So we got to monitor the effects of the patient when they have cardiac disease or diabetes. And this is the crazy part of this. These medicines can be used actually to treat diarrhea because, again, they form a mass. That's how they work, is they form a mass with of the feces. And you know, but a lot of times the patients are like, what, I'm not taking that. If they have diarrhea, uh, they'll say, I'm not taking that, that's what I use for my constipation. But it actually can help that if they just will give it a little try there. um, the surfactant laxatives decrease the surface tension of the fecal mass to allow water and fat to penetrate it, and so making it softer and easier to expel. So the surfactant laxatives truly have little laxative effect. They just kind of, if you will, do the stool softening. Lubricant laxatives lubricate the fecal mass and slow colonic absorption of water from the feces or fecal mass. So these medications may interfere with absorption of fat-soluble vitamins, and if aspirated, or some of these uh, medications in this list, they can actually result in lipid aspiration pneumonia. So what's going to be important in there is, if a patient is prescribed one of those, we got to make sure that they're swallowing okay, right? We would want to check that, because lipid aspiration pneumonia is not good. It's not good at all. Any aspiration is not good. Okay, let's talk a little bit more about bulk forming. These substances are largely unabsorbed from the intestines. Their purpose is to, you know, cause the mass there to form. And the pharmacokinetics of psyllium is what we're talking about here. It takes 12 to 24 hours for effect, so it's not going to work immediately. And of course, that's going to be a teaching thing that we'll need to do with our patients to let them know when to expect the effects. And again, the action is added bulk or enlarged fecal mass, and that stimulates the peristalsis and the defecation, and it can pull water into the intestinal lumen as well. We must add water for this to work. And the good thing about this medicine, it's very similar to the most natural way to help with defecation or stool constipation issues, and that is to add fiber to the diet. It also can be used to help with the use of an elevated cholesterol and diarrhea, as we talked about a minute ago. Now, we got to teach the patient to read the contents of the materials that they're using, or the chemicals that they're using. A lot of them, you know, they may have sugar, sodium, potassium, artificial sweeteners. So we got to be careful about diabetics here. Anybody with hypertension or renal issues, or phenylketonuria, or PKU, if you will. That is a rare condition that's inherited, and it's found in babies. They test babies for this, and it's basically that they have an issue with the breakdown of an amino acid that's called phenylalanine, and you know, so we have to be real careful with anybody diagnosed with PKU. We have to teach them about that as well. Now, let's see if there's anything else that I've missed with this. These are considered the safest laxative because they're like the dietary fiber, and they absorb the fluid and swell, stimulating that peristaltic action. Let's see. They're safe for pregnant women. They should be always taken with a large amount of fluid to prevent that obstruction of the esophagus or the bowel. So we've already talked about that as well. All right, I think we've covered that. Now, nursing implications. Again, we want to prevent interactions, any drug-drug interactions. It can reduce or delay absorption of certain medicines. Carbamazepine is a anti-seizure drug. Digoxin is a heart medication. Lithium is an antipsychotic. Your antidepressants, warfarin, you've seen that a lot. So any medications they need to take, either this medicine, these medicines 1 hour before or 2 to 4 hours after. So that's going to be important to do teaching with that. We need to, adverse effects are going to be gas, bloating, abdominal discomfort, and possible obstruction or impaction if it's not administered correctly. And of course, we're going to assess for therapeutic effects. So we want to always see, the end result is going to be, yay, no constipation, stools. And we always want to assess those adverse effects. Teaching, be sure to take a look at your teaching on page 692 in your textbook, because that is always a very important part of our job. Mineral oil, this is our lubricant laxative. So mineral oil is what we see used a lot here. So we got to be careful about that. I always think about lubricant, think of that song Paul Simon did, Slip Sliding Away. So, it does help. And, a lot of older people will tell you, they all had to take a dose of mineral oil. That's what their mamas did to make sure everybody stayed, cleaned out or whatever. So we got to think about that. So it lubricates the fecal mass there, and oils ease the passage of the stool. And the mineral oil is the one that's most often used, and it can be administered orally or as an enema. And the enema use is safe, and the effects is around 6 to 8 hours. Again, that adverse effect is lipid pneumonia if given orally and they are not swallowing correctly. So we must be sure they're not having an issue swallowing. We also got to consider about the decreased absorption of our vitamins A, D, E, and K for that, our fat-soluble vitamins. And this can be avoided by taking the mineral oil on an empty stomach and take the vitamins later. So we got to be sure to watch about that. Now, our surfactant laxatives, stool softeners, dulcosate calcium or dulcosate sodium, that's your main drugs that you'll study about. And, of course, these decrease the surface tension of fecal mass. And, it shouldn't be used to treat constipation because it doesn't treat constipation. It softens the stool. So it should be used to prevent constipation. So we, need to be aware of situations that can cause constipation and consult the physician to try to prevent it, to get a stool softener ordered, when we have situations that can occur like that, okay? It acts as a detergent, allowing fats and waters to mix, and it, again, has a little laxative effect, um, very little effect, but it will soften that stool, and that helps. It can be used to prevent straining when expelling stools. So, again, so we talked about how important it is for heart patients and hypertension, uh, anybody with a stroke, to not be straining. And so, a cardiac patient would be somebody that you would want to get a stool softener ordered so they don't have to do that. Um, also, patients receiving iron or calcium, those are medicines that can cause constipation. And so stool softener for them would be good. Another situation is after, excuse me, childbirth or surgery, where that perineum area is already tender. Getting a stool softener on board would be important. Um, we got to take a lot of water in with this, full glass of water taken with the medicine. Some of these will have a fair amount of sodium in it, so we got to be careful about patients who are on fluid or sodium restricted diet. And just remember that would be part of that sodium intake for them. And it should be taken daily. All right, and now we have our cathartics. So we got stimulant cathartics, which are the strongest and most abused. Laxative. Bisacodyl is our prototype for this. We also have castor oil, glycerin, and senna preparations. Now, the glycerin suppositories, they're okay to use with babies. They exert a hyperosmotic action within 30 minutes, so they work pretty quick. So the pharmacokinetics of this is these are medicines that are poorly absorbed. They are metabolized in the liver, and they stay in there, quite a long time. 16 hours is what their half-life is. Their action is that they irritate that GI mucosa, pull water into the colon, and stimulate the peristalsis. And they produce a watery stool. 6 to 12 hours for the effects to happen there. Now, the use, of course, is indication for this is constipation or someone with a neurogenic bowel function, meaning that they've had some kind of injury or some kind of illness that has affected that whole nervous system part that, uh, you know, uh, manages how we defecate, and so this can be used for those patients. We can either have these taken as by mouth or suppository, rectal. Need to avoid with children under the age of 6. And of course, adverse effects are going to be abdominal pain, cramping, nausea, diarrhea, and weakness. Nursing implications here, of course, anybody with an allergy, contraindications, undiagnosed abdominal pain, obstruction, or impaction. And we want to prevent interactions, so these meds can decrease the effects of bisacodyl and like anticholinergic drugs, H2 receptor blockers such as ranitidine, milk can affect the enteric coating of the medications as well. So, we want to avoid that. It can actually break it down earlier than what's expected, and we would have an earlier effect occurring, which might be something desirable for some patients. We want to administer this at bedtime and of course avoid overuse, because if we give too much, then the patient's going to have diarrhea and we're going to lead to loss of fluid and electrolytes and potentially cause an acid base imbalance. So we don't want to overdo it. And of course, always assess for therapeutic effects and therapeutic effects. And of course, we want to always do the teach, teach, teach to the patient. Now, our cathartics that are saline laxatives are classified under saline laxatives. I'm not sure why they call them saline laxatives. Some of them are certainly saline or sodium, but nevertheless, this is the classification. And they should actually call these osmotic laxatives because they work by osmosis. They pull the water into the bowel, and boy, are they strong. Magnesium citrate, magnesium hydroxide, polyethylene glycol, polyethylene glycol electrolyte, sodium phosphate, and sodium biphosphate. So those are the meds that you will see. Now, I will tell you this. When you take this medicine by mouth, it is god-awful. I've had to do it. And when it hits the taste buds, they immediately reject this. They do have some now that's not so bad, and you can mix it with, a Sprite or something to make it not be so bad. But some of it, it's like, OMG, this is not supposed to be in here. And I'll tell a story on my husband. We had to prep for a colonoscopy, and they gave him the Go Lightly, which is the sodium. Let's see, it's going to be the polyethylene glycol, and it tastes like you're drinking the ocean, salt water, and it's terrible. And as soon as it hit his tongue, he started vomiting. So he couldn't do it. He could not take it. So I had to go out and get enemas and get him cleaned out before his procedure with enemas. That was not fun. But anyway, the other thing is these medications, they work very fast, okay? So we got to tell people, hey, when you start this, these are your preps, okay? This is what we're talking about. Most of the time you see these used for prep, for surgical procedures or whatever. Now, for your older people, it can do a number on them. It can absolutely wipe them out. The prep for colonoscopies are the most worst part of that whole testing. Because when you go in and get a colonoscopy, they give you medication and you don't remember anything, and that's fine. I mean, it's that part of it's a breeze compared to the prepping. So anyway, be watching your older people, especially. It can wipe them out as far as dehydration, electrolytes, and things like that. So we got to be sure to watch them even more carefully. Your children and your elderly are always your most vulnerable population. So, again, this pulls a large amount of water into the intestines, and that's how it works, the osmotic pressure. And, it causes retained water and distension of the bowel, and that's what leads to the peristalsis and a decrease in that intestinal transit time for fecal mass. So you should be getting semi-fluid stools when this is used. And it works really quick, so they've got to be near a bathroom when they start that prep, or when we're giving it. We got to be ready for that. So again, they can lose electrolytes this way, and so we got to be careful. We need to be looking at their electrolytes before we give it, and we got to be monitoring them for side effects for this as well. So here's a picture of it. You can see the one on the right, the Go Lightly. That is a silly name to have for that. You don't go lightly, that's for sure. You go quickly. and you go a lot until you're cleaned out. And it is in a jug like that. I mean, I'm not serious. It is in a jug, and of course it's powder form when they give it to you, and you got to mix water in it. Oh, good Lord, be sure to mix water in it. But it is a lot of it tastes like salt water, and it's god awful. And then the one on the left is Fleet's Enema, which is, we don't use Fleets for prepping patients, but it is considered one of the saline cathartics. So the oral magnesium prep works within a half an hour to 6 hours. Oral polyethylene glycol, um, it can last 2 to 4 days of the effects. The sodium phosphate enemas work within 15 minutes. We got to watch about renal impaired with any magnesium product because they can retain that magnesium and become hypermagnesemia. So we got to be careful. We want to assess those electrolytes before. First, if we know it's a renal impaired patient, we got to watch about that and see if we can get something different ordered, if at all possible. Cardiac, the sodium products may cause them fluid retention and edema, so we got to be careful about that with them. Saline products used with caution in renal impaired and hypertension. Okay, so we want to be really, really careful with those patients on that. And again, the polyethylene glycol electrolyte solution, that's what's used for that endoscopy procedures, the GI procedures. Okay. Your lactulose exerts, that's a miscellaneous agents, and this is the one I was talking earlier about with folks who have that hepatic failure, the liver failure, and they'll have the hepatic encephalopathy. Um, you know, um, this medicine is what you're going to see ordered for those. It definitely has an osmotic effect, and it's a strong one as well. It pulls water into the colon and stimulates the peristalsis. It decreases the production of waste product from ammonia. So let's talk about ammonia. So you think, ammonia? We have ammonia in our body? Ammonia is the end product of protein breakdown and bacteria, and that's all done in the liver. Liver, we want to keep it quivering because it's important in our whole body function. So when the liver is impaired, um, we start seeing an elevation in this breakdown of the protein, and it can cause an elevated ammonia level in the blood. So the normal ammonia level is 15 to 45, and you don't have to know that at this point. But anything above that, a patient can start having that encephalopathy, the hepatic encephalopathy, which basically, what happens is cognitively they get confused, lethargic, lots of things, can happen with them on that, and at high risk for injury, of course, with that, and death as far as that goes. So, we got to get that ammonia level down, and lactulose is what you will see the most being used there. And of course, you're going to get a lot of stool after giving that, okay? Sorbitol pulls water into the, oops, I think that's a typo there, intestinal lumen, exerting laxative effects. Often given with sodium polystyrene sulfonate, or Kayexalate, if you remember that medication. It's used for hyperkalemia to get the potassium down, and that the sorbitol helps with the expulsion of the potassium resin complex there. That's what helps get it out of there. And then the lubiprostone, that is aids in treatment of idiopathic constipation, chronic, by increasing intestinal fluid and secretion and stimulating the intestinal motility and defecation. Okay, so sorbitol exerts an osmotic effect, pulling water into the colon and stimulating peristalsis, also useful in treating hepatic encephalopathy. So hopefully you chose false. Lactulose is the one that exerts that osmotic effect and pulls water into the colon, stimulating peristalsis and used to treat encephalopathy. Sorbitol is given with sodium polystyrene sulfonate in the treatment of hyperkalemia. Okay, so enough talking about our medicines. Let's get to the bottom line here. We got to assess the patients for current or potential problems, and so that means we got to talk to the patient. What's signs and symptoms? And we should be seeing decreased number and frequency of stool. The stool is dry and hard. Abdominal distension is what you might see, like a swelling in the abdomen and discomfort. Flatulence we may see as well, which is gas basically. We got to look for those presence of risk factors. So what's their diet? Do they have minimal amount of fiber in their diet? What's their fluid intake and what's their activity? We also got to look at drugs that they've been taking that can cause problems with this, such as your opioids, antacids containing aluminum or calcium, those anticholinergics, calcium channel blockers, clozapam, diuretics. Diuretics because it causes you to lose fluid. So again, that can cause constipation. Iron, the phenothiazides, cholestyramine, cholestyramine, sucralfate. So these are different medicines that can definitely cause issues with constipation. And then, of course, overuse of antidiarrheal agents can cause constipation too. We got to look at conditions that have caused reduced intestinal function of the patient, though. Do they have depression, any kind of eating disorder? Hypothyroidism can cause problems. Hypercalcemia, calcium meaning there. Multiple sclerosis, Parkinson's disease, or any kind of spinal lesion, like I was telling you, the neurogenic bladder. Hemorrhoids and anal fissures and other conditions that might have caused painful bowel elimination, and of course our elderly or any debilitating status. So our implementation is we're going to help the patients and caregivers, because I think that's going to be important as well, to understand the importance of the diet and exercise and fluid, and increase that activity and exercise if possible, and to increase the dietary fiber. We want them to drink at least 2,000 mLs of fluid a day if it's not contraindicated, and to maintain that routine bowel elimination and understand and comply with drug therapy if in fact they are going to be having to take something. And then, of course, we're going to monitor the response. Record number, amount, and type of bowel movements, and record vital signs, and watch about hypotension and weak pulses that may indicate a fluid loss. And we, again, evaluate therapeutic effects and evaluate for adverse effects. Always, always, always. Okay, that concludes your podcast.